The third lecturer of this block is Frank Sullivan. He's a professor of primary care, and until recently was the director of the University of Toronto's practice-based research network called Utopian. Believe it or not, in exactly one day, he will take up the chair of Professor of Primary Care Medicine at the University of St. Andrews, which is, compared to the University of Göttingen, the third oldest university in the English-speaking world, founded at the beginning of the 15th century. Congratulations, Frank. Of course, he is, I mention that with every speaker, a real doctor, a general practitioner, a devoted general practitioner, and his clinical work as a GP in Scotland was mainly in two socio-economic deprived inner-city practices in Glasgow and in Dundee. Frank actually runs a couple of large trials in the UK, but as many of you know that probably, his most famous paper was about Bell's palsy, published in the New England Journal of Medicine in 2007. Now, I know Frank for more than 20 years now, and I take the liberty to say a word about his provenance. Funny. He still works in Toronto, and you might think he's a Canadian, but he's not. Being born in the UK, you might think he's British, but he's almost not. He's a proud Scotsman and has a fair chance to stay European when his First Minister, Nicola Sturgeon, is successful in 2 years. Okay, enough about that. The title of his lecture is derived from one of his large trials, actual trials, Treatment Options of Infected Eczema, the CREAM study. Frank.
Thank you, Michael, and thanks to everyone being here today, particularly to Ildiko, or as Michael has just explained, I should refer her to as Privat Docentine Dr. Gagior, with her recent success in the So this is, I'm delighted to be here for this symposium on infections. And I'm going to speak about this study, which has been really something I've been working on for 8 years. But as you've heard, I've been in Toronto for 3 of those years, so most of the credit really goes to my colleagues in Alistair's department in Bristol and to others in Cardiff, Nick Francis, who led the study. So this is what we're talking about. Can I ask everyone to stand up so I get an idea of how much interest this is going to be? Can everyone stand up, first of all? And then everyone who's not a family physician or proper doctor, as Michael says, sit down, and the family physicians stay standing up. Everyone else sit down who's not a family physician. And then those of you who see infected eczema in children, stay standing up. Everyone else, sit down. So some of you are not seeing very many adults. So the final people standing are those who would treat this kind of problem by adding steroids to the normal, to adding antibiotics to the normal treatment of childhood eczema. If you would just carry on with emollients, moisturizers, maybe increase the dose of the steroids. So nobody here, this is not a common thing. But in the UK it became a question because it's such a common problem. a quarter to a third of children will get some type of eczema, either atopic or otherwise. They will often flare up frequently, and at the time we were starting the study, children were being treated once or twice a year, those with eczema, by getting antibiotics. But there were questions around what really was infection and when should children get these anti-staphylococcal treatments. As often, it arose as a major study problem because a Cochrane review flagged it up as an issue. In 2008, there had been 21 trials involving 1,000 participants. As so commonly happens when we look at primary care problems, the review said we don't really know what to do. And they said that more studies were needed. And in the UK, what happens now is that the NHS looks at all the guidelines and the recommendations and calls for research on the ones where there's not already a good answer. We think the other issue was that the pharmaceutical companies started to introduce topical treatments containing topical antibiotics, and these started to be used more and more frequently. So in Tayside, where I was working in Scotland at the time, we could see this fairly rapid rise from the time of the Cochrane review saying, we don't know whether to treat with antimicrobials. Everyone started treating with antimicrobials. And that was what increased the importance of the issue. So this study that we applied for, say, led from Cardiff, but involving Scotland and Bristol, was to try to determine whether oral or topical antibiotics, in addition to standard treatment, produced an improvement. So that was the study question. The inclusion characteristics were children aged 3 months to 8 years who had atopic eczema, as defined in a UK working party. And it was suspected that their eczema, which had flared up, was infected. Now you can see from the picture here, it's not impetigo, it's not frank, crusting, yellow infection which would have required antibiotics. And we also excluded children who had been treated within the past week or had been given very potent topical steroids in the past 2 days. So it was a relatively difficult group to define in the study, and you'll see that that may have influenced what happened. This is what we had said that we were going to do when we applied for the funding, get a little over 500 children who met the inclusion criteria. They'd be visited at home by a nurse within 72 hours to check through the baseline characteristics. We didn't think that the practices would be able to do that baseline assessment within a 10-minute consultation, which is still the standard in the UK. So nurses, once they'd been alerted by the practice that there was a potentially eligible child, then they went out and saw the child at home, and then those who were eligible and gave consent were randomised. They all were given moderate topical steroids and emollients to moisturise the skin, but there was a double placebo group, tablets and cream, and then the antibiotics either orally or topically. They had follow-up after 2 weeks and 4 weeks by the nurse going into the home to examine them, and then their medical notes were reviewed after 3 months to pick up on some of the other variables that we wanted to study. At the beginning of the study, and I think this is the reason why I got involved with it in the first place, we thought that we would use a software which alerted the studied nurses to the fact that the doctor had seen someone, and would alert the GP as well to the fact that a potentially eligible child had been seen. And probably this graphic is the best part of this part of the study because it didn't work. We had it working with one system in Scotland. We had successfully used it. But when it went to England and Wales to try to be used with different systems, it was a complete disaster. And we had to abandon the use of this great idea at this point. These were the measures that we used. The main study was powered on the POEM score at 2 weeks. We were meant to have the 500 children in the study, and they also had a bunch of other standard validated examinations, including ones looking at impact on the family, quality of life and adverse events. But the main measure was this POEM score. The daily symptom score included all of the kind of things that you would expect in a study about eczema. Because there were children 8 and under, the carers' assessment of overall severity, that also measured itch, how disturbed their sleeping was, oozing, etc. And it was scored from 0 to 6. We're on to the next 2 slides about problems that we encountered. And the first one was one that anyone trying to do studies soon encounters, that the patients that you want to study disappear. We had done pilot work in 70 practices in Scotland, and we found that there was between 0.2 and 0.3 children seen with infected eczema for every 1,000 people on a standard practice list. And that meant that between 1 and 2 per month would be seen. So we would see between 118 and 158 children every month potentially eligible for the study. What actually happened, and looking at the data in the UK's CPRD during the course of the study, is that the numbers were all much smaller, about a fifth to a sixth what we had put into the proposal based on our prior observations. So always be conservative in that part of it. The next problem was clinicians deciding that someone should go into a study, that they had to be in equipoise about whether this was a potentially eligible child. So if it was very obviously impetigo and severely infected, they definitely need antibiotics. If it was pretty mild, they probably just get on with the emollients and not bother. And so this is what Mark was talking about the, where the child lies on that axis with the red and blue arrows about thresholds to treat. There was a problem in the whole recruiting of sites, and we had to expand into secondary care. Because again, a change that happened over the 8 years of the work that we did was that paediatric dermatology nurses became an important part of the way that these children were looked after. I've already mentioned that trial torrent was dropped, there was a big dropout. About a third of the children who were identified did not get recruited. And that was mainly because in the 72 hours, or up to 72 hours before the nurse saw them, either they got better or the parents changed their mind about whether they wanted them to be in the study. So we did try and address all of this as we went along. We changed the protocol and got permission to do so, to expand the age range up to 8. We reduced the number of visits. We reduced the burden on the families to try and make it all a bit more manageable. And as I've mentioned, we expanded into other recruitment sites. We revised the sample size calculation. Based on the first 69 patients, we found that what was in the literature was more pessimistic, and we were able to reduce the number of children that we were looking for from a bit over 500 to a bit under 300. So we thought this was good, and we got approval to make this change, which was unusual. But what we actually did was enrolled only 113 children into the study. As I said, about a third dropped out, even after all our efforts, and we had to eventually draw a line under it and analyse the data on the 89% who were still in the study. So we're down from 500 to 100. So you think, well, why is he presenting? Why is he talking to us about this study? Before I get to that, the only other thing to say was about the baseline was that there was a bit of imbalance in the three groups. By chance, the group who were given oral antibiotic did have more staphylococcal colonisation of their eczema. But these are the results, really. The line, the filled dark line here, is the control group who just got the treatment that all of you would have given before you ever heard about this. That they got better just as quickly. And their POEM score dropped down just as quickly as the ones given oral or topical antibiotics. There was enormous heterogeneity in the actual scores. The total daily symptom score shown here is the same thing. And really, had this been a sequential trial where we had stopping rules for futility of carrying on, we probably would have stopped it anyway after 100 patients. And I suppose that was perhaps what saved us. When we put these results into a meta-analysis, it showed up really that a minimal clinically important difference in the main outcome variable, POEM score, would be around 3.4. But actually, we only saw a difference of 1.5, and it was across the gain line. That's it for oral antibiotics, and somehow this got switched around in direction for topical antibiotics, but in both cases, it confirmed, even in adding it in to the other studies that were similar to this, to show no benefit. Concluding now, the limitations were we really failed to have an agreed approach on defining or assessing the severity of infection. The participants who had mild eczema, and we told the clinicians to exclude the ones with more severe. We probably couldn't exclude a small, really clinically unimportant benefit, but it did allow us to conclude and publish in Annals of Family Medicine that there isn't any value on adding antibiotics to the standard treatments. Actually, on Alistair's website for Bristol, that gave you the answer because it was one of the news items from the web link that he had there. Adding the oral and topical antibiotics didn't really help, and it was just exposing children to the additional risk and the community to the increased risks of antibiotic resistance. I've also put in a couple of other conclusions that I still think that computerized alerts may be very helpful in this kind of research, but it needs a good deal more field testing. Anyone who tells you that the software will work, don't believe them. See a demonstration in the systems that you're going to use, because it needs a lot more. But finally, and I think the main thing is that even studies that are underpowered still can produce valuable results. I think we can be quite strong, and we've had several ways of disseminating this information, which just still makes it a useful thing to do. And that's the final slide. Just acknowledging again the input. It was a big burden, particularly in the parents in this study. All the clinicians, Nick Francis in Cardiff, who really led it, particularly as I had gone off to Canada, and the Department of Health who funded this. They gave us the money. We came up with an answer, not quite as well as we'd have liked to have done, but hopefully it's of some value. Thank you. No questions on that one.